Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to the Senior Resources Show. My name is Christine Carey and I'm the Director of the Town of Colonie Senior Resources Department. I'm glad you've joined me today. My guest today is Dr. Michael Dailey, Medical Director of the Town of Colonie Department of EMS. And I'm thrilled to have Michael here because I think the topic is very compelling and interesting. It's also a topic that both seniors and their loved ones need to be aware of and need to know about so that they can make informed medical choices and decisions for themselves and their loved ones. Michael, thank you for joining me today.
My pleasure, Christine.
I'm very interested to learn more about the Medical Orders for Life-Sustaining Treatment MOLST program. I learned about it recently when I read an article in a newsletter from the New York State Office for Aging, and I thought to myself right away, wow, when did this come about? I didn't know anything about this. So if you could give me a little bit of the history on the MOLST program.
I'd love to. MOLST actually stems as slow growth across the country. It started as the Physician's Orders for Life-Sustaining Treatment and has morphed into the Medical Orders for Life-Sustaining Treatment as it approached New York. It started actually in the Northwest, the Pacific Northwest, in Oregon and Washington, as people were realizing that they needed a more standardized method of recording end-of-life choices for patients so that patients would be cared for the way they want to be cared for. And also the other thing that it does is it structures conversations between physicians and patients. It's very difficult to have end-of-life discussions with patients. Sometimes it's easier just to slip into the acute medical care and not to have conversations about what patients would really like, what the results of those interventions really will be. And instead of just giving medical care, now a physician can sit down, discuss this form with the patient, spend some time, really quality time, talking about what that patient, what their family really would like, and what the expectations from some of those interventions should be.
Mm-hmm. That's very good. What has been the response from the medical community as far as, doctors have so little time? I hear it often from the folks I help, that when they go to the doctors, there's so much information to be covered in a short amount of time. How has the response been from the medical community? What
I've seen from the medical community has actually been great response. The thing that we're having the most trouble is getting the document out and teaching them. However, the New York State Department of Health and Excelis Blue Cross Blue Shield have been working to get the information out there. There's a website at compassionandsupport.org. That website has a significant amount of information both for patients as well as for caregivers, and specific information for physicians as well that can guide them towards working on completing this form.
Mm-hmm. Yeah, well, it's a bright pink form, so I think when folks see it, they'll know what it is. And do doctors have this form in their offices to be able to, present this? Is it something that's when a person has a chronic illness that the doctor brings this form out, or does the patient bring it to the doctor and say, let's talk about this?
That's great. I think that's two parts to that question. The first is, where is it?
Mm-hmm.
It can be, anybody can order one, or physicians can order many from that compassionandsupport.org. More and more physicians will have them in their office for their patients over time. In particular, physicians specializing in geriatrics, mm-hmm. And physicians in things like hematology and oncology will certainly have these available to their patients. The other part of the question really was, who should have the form? I think there's two groups of people in particular that should have the form. One is elderly patients who have very specific wishes about their end-of-life care. The other is people who believe that they are in their last year of life. Mm-hmm. It's very difficult to estimate what the last year of life is going to be. But if somebody has specific wishes, they need to make sure they're documented and documented well. This is a good way to do it. Mm-hmm. This is not for someone that's my age in a relatively good state of health, I should have what's called a healthcare proxy. That healthcare proxy is somebody that I have signed a form with, that they know my wishes, and they will be able to then carry on those wishes should I be unable to communicate them myself.
And that was my next question. Does this form in any way replace a healthcare proxy or a living will? And maybe if you could touch on what a living will is, because I think there's a lot of confusion. I hear from seniors particularly that very often, well, I have a living will. Well, a living will can be very limiting. And so I think it's important to give a little background on what the two documents are and how they work with the MOLST.
You're absolutely right, Christine. There, right now in New York State, until the MOLST, there were 3 documents. There was a healthcare proxy, which essentially designates a person to care for you and make decisions on your behalf. There was a living will, which is made with an attorney, very frequently no physician involved, and is a very difficult document from time to time to interpret, but is designed around the idea of defining your choices. And then there was the pre-hospital DNR. The pre-hospital do not resuscitate form only pertained to what would happen if your heart would stop. It didn't pertain to any other situations of medical care, so it was extremely limiting. What the MOLST does, very clearly first, it's something that anybody can see. What the MOLST does is it travels with you. It travels with you to the hospital, it travels with you home from the hospital. It travels with you to a nursing home or a rehabilitation center, and it travels with you home again. And therefore, it is your care. And it really is a clear representation of a discussion with your physician about your wishes around the end of life.
That's interesting. Now, I question the transporting of this document, because I have a family member who's in and out of the hospital with chronic heart disease, and every time we go to the hospital they say, did you bring a copy of the healthcare proxy form with you? And sometimes we have it, sometimes we don't. The hospital has it on record, but it's down in files somewhere and it's impossible to get to it. So when a person is discharged from the hospital, they're given this form back, and then it's their responsibility to have it with them should they go to the hospital again.
The optimist in me says that every time a patient goes from one place to another, this form will accompany them.
Okay.
The realist in me says that it won't be there every time. A copy of the form can be honored.
Okay.
However, that doesn't mean if a patient is in a rehabilitation center, the rehabilitation center should keep the original and send a copy. What they should actually do is send the original and maintain a copy in their files. When you get to the hospital itself should keep this form in your record, because there aren't a lot of pink forms at most hospitals. This should jump right out of that record at the physicians and nurses caring for you if there's an emergency situation.
Okay.
One thing also that's being worked on, which is an interesting twist, is that some of the hospitals are in the process of moving to using this as their only in-hospital documentation for patients' wishes. Currently, each acute care facility in what we call an Article 28 facility, either a nursing home or a hospital, every single one of those facilities has their own do not resuscitate paperwork. What this is going to do in many of those facilities is replace that and instead very clearly document the patient's wishes.
So if the hospitals move towards this document and an individual goes into the hospital and the nurse comes in to do the first assessment that is done, will she be pulling this form out and going through it? Does she have the authority to do a MOLST form with a client, or is it the doctor that has to sit down and do it with them?
The physician ultimately has to sign it, but who has that initial discussion will pertain to each care setting, and each care setting may be different. You may find in some settings it'll be a social worker that approaches a question with a patient as the patient has provided an opening in a discussion. There have been many situations where a patient has mentioned an interest to a physician, a nurse, a medical student as part of the care that we're providing, and we've sent other people in to have that discussion.
Okay, so when the MOLST is being completed, and the individual already has a healthcare agent, healthcare proxy. Is that proxy part of the conversation? Because many times I hear from folks that they have an agent, and I say to them, well, have you discussed your wishes with your agent? Well, no, they signed the form. So that, you don't want the healthcare agent to be in a situation where they won't know what their parents' wishes are.
Right. No, that's very true. And the proxy should be an acute part of this, because the proxy is going to be in the difficult situation of saying, these are the wishes of my mother, these are the wishes of my father. And if they're there for the discussion, they know what those wishes are. The other two things that'll be in the record, A, the MOLST, which are actually physician orders, and B, the documentation of the conversation with the physician. There's actually a specific documentation form that a physician can choose to use. In both of those cases, what that'll mean is the patient's wishes will be right there, so the proxy can't wonder about what they should do.
Okay.
The other thing I'd really like to highlight is that this is the patient's wishes, and this actually is something that will be followed in the hospital, because they are physician orders.
Oh, that's critical. That certainly is an important component of the MOLST. Tell me how this works in the community. We've talked a little bit about how it works in the hospital, but seniors, I don't know what the ratio or the percentage of the EMS calls that Colonie receives that are for folks in the town over 60. And I don't know if you know what that number is, but I know they're big users of the EMS services. So how would this work in the community if, say, EMS was called to a home and the person did or didn't have a MOLST form?
If EMS is called to a home where the MOLST is, our providers would look at it, document it on their patient care report, and make sure to transport that with the patient to the hospital. It's important to recognize that Colonie EMS was one of the first agencies around to get 100% training in the MOLST, because we're firm believers in the town of making sure that our providers are on the cutting edge. And as soon as this was passed and being able to be used statewide, we wanted to make sure that our EMS professionals will be able to support the wishes of our seniors that may have these documents and may have brought them in from somewhere else. In New York State, this program was started out in Rochester and went through the community out in Rochester extremely well, and has been demonstrated to be very, very effective at making sure that a patient's wishes are followed, and we wanted to make sure that same thing was happening here in the town of Colonie.
Yeah, oh, it's great. That, as you were speaking, it raised an issue for me. We have a lot of senior residents in the town that are snowbirds and go to Florida for the winter or go down south. Does this form travel with them, or do they have to have a Florida MOLST form, or whatever the form would be that would be appropriate to where they are?
That's a great question, and I don't know the answer to that.
Okay.
That's certainly something we can bring information back.
Yeah.
The one thing that's most important, every state is going to have different laws about end-of-life issues, but the one thing that seems to hold true and has gone all the way to the Supreme Court is how end-of-life decisions can be made by your proxy for you. Terry Schiavo is one case that comes to mind, where the family had one set of wishes, healthcare had a different set of interests, and it was a very long, protracted course between the time that she suffered a fatal brain injury and the time that her body ultimately died. Her family during that time went through an awful lot of court decisions. What this MOLST would definitely do is provide clear and convincing evidence for any caregiver for you if you were to be in Florida or Georgia or Alabama or Texas or Arizona or wherever you happen to go, that there the caregivers would be able to see what your wishes were.
Oh, that's great. Now, as far as the form doesn't look difficult to complete, it looks pretty user-friendly, but there's a lot of information that's captured on this as it's needed to be. Does the form have to be completely filled out by the patient, or can they skip certain pieces of it and it's still an effective tool?
It's actually the physician should complete it with the patient, so they should be doing it together as a team. And it's really important to make sure that the form is filled out completely. All the pertinent right are completed, because otherwise we won't have an idea of what to do.
Right.
If you look, Section A on your form that you hold in front of us, we have slightly different copies of the form. But Section A on that form is specific to what to do if your heart stops. And that's going to be the first thing that we'll want to look on and find an answer to. You'll see that there are two options. One would be resuscitative measures, and the other would be either what we used to call a do not resuscitate, or what I really prefer to call allowing natural death. There is so much negativity associated with the idea of do not resuscitate.
Right.
Oh, we're going to do nothing. It's not true. We're going to make somebody as comfortable as we can and allow a natural process to occur. For a lot of elderly people, a cardiac arrest is going to be a terminal event. It may not be a terminal event immediately, but the chance of regaining normal life is extremely slim. You may have seen a case that we had of a cardiac arrest here in the town. We've actually had great publicity for several resuscitations that we've done relatively recently. These were young people in the prime of life with immediate CPR that got rapid defibrillation, and they had a lot of reserve. The elderly have less reserve. The opportunity for a resuscitation that is ultimately successful is much lower, and this is something that's very difficult from time to time for physicians to discuss with their patients. But it's important to recognize what the care that's going to be given to you will result in.
It really behooves the patient to do some research and really have discussions with their doctor and with their loved ones about what their wishes are, because the way you described it to me just now is, yeah, you know, it really makes me stop and pause about what does do not resuscitate mean. And your description of it is probably the description that most seniors, you know, would be the choice that they would want to make at the end of their life, or if they were to have a major event.
There's been some research that's been done in the state of Oregon that's really telling, which is some specific education around the MOLST document, and then looking to see how people's answers have changed. Basically, what are the results of care going to be? Asking them, would you like to be put on a breathing machine, or would you like to be intubated? Patients don't necessarily know what that means. There's some patients, when they're asked, that believe that that means that they're going to have an oxygen tank, like someone you might see in the mall. There's some patients that aren't sure what that means at all, but won't question the physician at that point. And then there are others who subscribe to the idea that we've unfortunately taught them on television.
Right.
You know, while you shouldn't believe everything on television, except what we're telling you right now, on television, if you were to watch cardiac arrests, on most of the TV shows, there's a greater than 2/3 survival rate. That's not true. In real life, cardiac arrest is almost always a fatal event. In fact, that's what happens about 85 to 90% of the time, regardless of what the initial presentation is. In certain situations, there may be a slightly different numbers to that, but in the elderly, the numbers drop to below 5%, and the numbers of people that regain a life that they consider normal are very, very low. When people see those numbers, their wishes are much more clear.
Yeah, that's excellent. That's very true. Now, as folks are trying to fill out this form, and I think first people have to do a lot of thinking about what their wishes are. Where do they begin to go to get more information with documentation that they can read that would help them to kind of figure out what their wishes are before they enter into the form? Because I think there needs to be some thinking about those issues and discussion with family members. So where can people start to get information? I would imagine their doctor?
Their doctor may have some. They may have to bring that information to their doctor because their doctor may not have yet been educated. The other place to turn would be senior services. You and I are going to work later today at making sure that we can get all of the resources available to you so you can get them out to interested people, because I'm sure people are going to see this discussion and want to get these forms and want to get more information. The other thing is they can go onto the internet to compassioneandsupport.org, and we can link that off the website as well. We can also, I believe that there's information on things like the AARP website as well, although I'm not sure about that.
And we can put some links on the town's website.
That would be a perfect place for the information.
For people to start, and through our department. Have you seen the MOLST form out being used in the hospital setting as well as with EMS so far, since this has become law?
We've seen it a few times in the hospital setting. As I said, I work at Albany Med, and we've seen a number of these come in so far. We're starting to see more and more of them, and it's very comforting in the emergency department to immediately know what a patient's wishes are and know how to guide care there. That's extremely useful. We've seen a few of them in EMS, and right now, I was actually out with EMS last night taking care of a patient who I really wish that we had a MOLST form on, because there's some sections on that MOLST form that I think would be very, very pertinent to many seniors' care. And this person in particular would have benefited.
Yeah, that's got to be kind of tough for you to see those situations where you think, wow, if this form had been in place, maybe there would be a different outcome, or maybe the person's wishes could have been, you know, respected more.
Right.
Well, we will certainly make this information available not only to the town nurse as she's out in the community. We're very fortunate in the town to have a town nurse who does a lot of home visits and does a lot of education with seniors around all these types of healthcare issues. We get calls almost daily in our office for folks requesting healthcare proxy forms. So now we have another document that we can give them so that they can be, they can make really educated decisions and have the tools in place so that their wishes are respected. Now, we are going to be having a health fair in the town on April 30th at the crossings, and I urge all the viewers to stop by the crossings on April 30th from 1 to 4 p.m. And I know we'll have information there on the MOLST form, so hopefully you'll be able to give us a nice big pile of them so that we can make them accessible to seniors and to family members and town residents that come out for the for our health fair. So just making a little plug for that event. Is there anything else that you'd like to add about the MOLST program, or some of the things that seniors and their families should think about before completing this form, or any types of suggestions that you can make?
No, I think the suggestions I think I would make would be consider what you want, discuss what you want with your physician, with your family. Learn about the MOLST form, and above all, make sure that you've had these discussions in the light of day prior to getting sick. It's a lot easier to make decisions when they're not being made acutely in critical situations.
Right. Prevention, it's the key to everything, right?
Exactly.
You know, good health and living a healthy lifestyle, having the appropriate documents in place for those crises and critical situations is just part of having a good preventative plan in place for yourself. Well, I want to thank you very much for joining me, Dr. Dailey. This was excellent information, and I hope that our viewers really take this into consideration and have this form as part of their healthcare plan. So thanks for joining me today.
My pleasure. Thank you, Christine.
You're welcome. Thank you for joining me today. I hope you found this information as useful as I have. I hope to see you again next time. Thank you.